All right, everybody. I have on Dr. Robyn Thompson today, and I'm so excited to chat with her. She is a respected midwife, a maternal child and family health nurse, breastfeeding specialist, and the founder of the Thompson Method breastfeeding program. She has 45 years of experience as a hospital and home birth midwife. And
50.
she, oh, 50.
50.
Okay, they got to update this. 50 years. Wow, that's so amazing. And she is no stranger to the hardships of motherhood. And she is here to chat with us today. So I'm so honored and excited to be talking with you today.
Thank you, Elizabeth.
And she's coming to us all the way from Australia. So it's evening where I'm at, it's morning where she's at, but we made it work. So technology is, to me, extremely frustrating, but also really amazing, right?
Yeah.
So before we dive in, I would love for you to share with us what made you want to become a midwife, and then from there, what made you want to go on and do all the amazing things that you've done and develop the Thompson method and all of those things.
Well, I'll do my very best. I never planned to become a midwife. I never planned to become a nurse. So I've been 61 years in the Australian health system, and I'm 79 and I'll be 80 next birthday. So
That's
I've
amazing.
I've been with, with beautiful mothers and babies for a long, long time now. But my nursing career, then three babies actually, because I had two little babies and then a stillborn baby later. And then I decided that I needed, after 9 years at home with my children, well, my eldest was 9 years home, 2 years less with my daughter, so 7 years at home, being the mother I wanted to be and not going back to work, which I think is a problem for a lot of women now, is expected to go back to work. We should be paying them a wage to be with home with their babies because they're working full-time unpaid. So I'm a promoter of that. And then I decided I wanted to do something, but I didn't know what. But I thought, I was going to just go back to nursing. You know, I'd been doing a little bit of casual work more than anything over the time, and I thought maybe I'll just go back. And then I thought, maybe I'll apply for midwifery. So I applied for midwifery, and there I was in 1974, accepted as a midwife. Then after finishing my midwifery, 3 months after finishing my midwifery, I was placed in charge of a public hospital labour ward. So I had over 10 years in the labour ward working with beautiful mothers and midwives, and nothing in my life has ever been planned. It all just happened. So I was told I was going to take this position. I wasn't asked did I want it. And then that led me to many, many more things, beautiful experiences through my whole career. And then I was speaking at a conference in Northern Australia, in the Territory, and I was, would you say, coerced by 4 leading people of this country, 3 guru professors, midwifery professors, and 1 scientist, asking me what I was doing with my work. And then I said, I'm just sharing it because I'd been wanting to know why so many breastfeeding women coming out of the hospital had complications, why I didn't see that at 25 years of birthing at home with women. So of my 50 years in midwifery, I had spent 25 birthing at home with women, and I wanted to know why. So that led me to research, which I was very reluctant to be part of because I didn't see myself as an academic. And I was loving my career, so I didn't anticipate I needed any change at that time. So then I went on, and after a year of being enticed, I started a master's degree, which is a 2-year degree in the Northern Territory. And then at the end of the first year, I was called up to the head office to all the gurus, and I was really scared because I thought I was in trouble. And it was to tell me that I didn't need to finish my master's, that it was being converted to a PhD.
Oh, wow.
So then, after gathering myself, I started a PhD, and that's what's led me on this journey now, because I was making a difference for women who had complications, who had pain, and in one session I could have them pain free. And I studied and I studied and I studied. I didn't stop studying, and I'd look at something new and something new, and I'd go on. And I wanted, because I was always asking why. So I'd look to see why, and then I began to understand much, much more. And for 50 years, the teaching we have now has been happening, and we here in Australia are still seeing women with lots of breastfeeding problems, even though they've chosen to breastfeed. So it's really sad in a way, because a high percentage of it is preventable. There's a whole lot of things that are preventable, and I think since we've institutionalised women, we've taken control of them, and we don't stop and listen and think and observe quietly, and we stand over, and we use our voice to dominate, and we use our body language to dominate, and we don't do that intentionally. It's the way it's being educated, and so I think there's a real problem. And again, that's why I'm doing what I'm doing, hopefully fitting it all in before I die.
Yeah. Well, it's interesting that you said, there's been such a change even with this education, right? And more women choosing to breastfeed, but yet we're still seeing a lot of these issues. And did you see a lot of those same issues at home births that you see at hospital births?
Yeah, that's what made me ask the question, why? Because I didn't touch the babies at home unnecessarily at all. And that baby belongs to its mother. And we need to recognise that, and we need to not think that we have to deliver babies. Women give birth to their babies, and that women can do what they want to do with their baby. What we're doing is observing the mother and baby, just making sure everything's in the zone that we believe and are educated to know is safe. So we're not interfering unnecessarily. And listening skills are so important. So I still see the 50-year teaching happening here. I have hundreds and hundreds of women telling their stories when they're talking with me, and it's pretty horrific, some of the things that are happening to women right now. And it breaks my heart, because there's no need for it. Absolutely no need for it. Since I have got a presentation called the Isation Syndrome, and I've built that up, and it's all about institutionalisation, medicalisation, and all the things that go with that, even midwiferyisation, lactationisation, the whole politicalisation, the politicians becoming involved in things they should never be involved in, that they've never ever studied for. They've never been in a position to give orders to anybody about our career. And in here, if you're a midwife in your own right. You're not under medical control. You're not medicalised. And they could learn a lot from us. And the doctors that I used to work with, who were interested in what I did, who came to home births, were blown away. They were absolutely. And one of them used to sit on his hands, and I asked him why he was sitting on his hands. He said because the midwives in the UK taught him to. There is a big problem around the world at the moment. If you're following around the world, you'll see the midwives are rising, the women are rising. They've had enough. Enough is enough. They've had enough.
Yeah, that is so true. And even here in the States, there's an OB. He used to work in the hospital system, and now he doesn't anymore. He's part of a program in the United States reteaching breech birth deliveries to midwives and doctors. And he and this other midwife have a podcast together, and they always talk about sitting on their hands, like the art of doing nothing, like your need or want to intervene, to be like, oh, I should, because then you feel like you have some sort of control or you want to be a part of it. But there's an art to sitting back and doing nothing. It's like your presence there is strictly if something were to be wrong. And that isn't super common. Like we think that it's common, but people are also very miseducated in the fact that a lot of the problems that they think that they're being saved from, the hospital created in the first place.
That's right. It's absolutely right. And the cascade of intervention has led to the highest cesarean section rate. It's just so high. So that's major abdominal surgery.
Mm-hmm.
And I wonder how many women sit down and have been talked about the process of what major abdominal surgery is. And I see so many women with complications. And for example, 3 in the last year who've had open wounds right through to their peritoneal cavity that haven't healed. One was an American woman, and it took her 10 weeks to be able to see a nurse for it. And she's come out the other side, and she's back. I actually suggested she gave up breastfeeding. It was all too much.
Mm-hmm.
Anyway, we've reconnected, and now her milk volume's coming up, and she's breastfeeding, or she's aiming to breastfeed her baby. She's heading in that direction. So it's pretty, and there's a lot of other horrific stories which I won't tell now, but so many women speaking out, and it's time they did speak out.
Mm-hmm.
Time that our bodies were respected, and that we do what we know we can do, and we call on help when we need it, and we stop the horrific intervention that's going on.
Mm-hmm. Yeah, absolutely. I loved that you mentioned earlier when you're just kind of even talking about like being educated even in the posture of how you stand over or speak to people, because one thing that I just see a lot is just women not being heard in labor. And that's like from the very beginning. Like I'm sure, I mean, obviously you've heard so many more stories than I have, but even I just get so frustrated with the stories when they're like, I got to the hospital and I'm like, I need to push. And they're like, no, you don't. We just checked you. You're only 6 centimeters. And they're like, no, I need to push. And they're like, no. And then they check them and the baby's head's right there. And then everybody's freaking out. And I'm like, I don't understand why. Like, you're just not listened to in the first place. What's the harm in if somebody's like, I feel like I need to push, and letting them trust their body, first of all, and do what they feel like they need to do. But even like let's say they have an epidural and they want to check them or whatever, like what's the harm in just checking, and just being like, oh, you're right, honey, like let's get your dog, whatever. Like just the stories of misbelief when they're like, no, something's not right, or I need to do this thing, and just being told, oh, no, you don't. Like those stories. And those are like the mild cases of not being listened to. Like those things just frustrate me so much because I hear it all the time. And I'm like, and that plays into your breastfeeding journey, your motherhood journey. Like we're taught to not trust ourselves, not listen to ourselves. We're trying to, and then you're being shut down. And it's like, you don't even know how that's like affecting you later, even in your journey.
Conception, pregnancy, pre-labor, early labor, established labor, giving birth, and breastfeeding and mothering, parenting is a transition of life.
Mm-hmm.
It is not segregated into parts. It's not broken into parts, yet we break it up into parts. So we treat the woman and her body and her brain in sections, and that's not the way to go. She's doing what she needs to do genetically, biophysiologically, her anatomical state, her family's anatomical state. We're telling women their babies are not putting on enough weight, but they're growing tall. Their head size is growing because there's tall people in the family. And every other sign for the baby is perfect. So we're not even learning to be able to, we're going on rules and that fit every single baby in the world, and that's not how it works. We need to be much wiser about the unique mother and the unique baby, and not be so overwhelmingly disempowering for her. It's a real difficult situation that we have now. We've always had something happening on and off, but this is really becoming, and it's more, I suppose, because of technology and that it's more known worldwide now. And like this, we can communicate, and there's been a federal government in the state of New South Wales uh, um, investigation into obstetric abuse. Now, I've never heard of that in my whole career ever, not right through my whole 61 years in the health system. I've never heard of that, and that's been going on here. And then there's 3 hysterectomy groups that I've looked at, and they're all talking about the same thing. They're not, the 3 groups, one in the UK, one in New Zealand, and I think the other one's here. So they've been like, that's crying out now too. So there's a lot of consideration to be worked through. And as you say, we need to listen to what the woman is saying, what she is doing, how she is working with her unique body. She doesn't have to do the same as every other person on the planet who's giving birth to a baby. She does not have to do that. And you know, when I think about it much deeper, the mammals don't have to do anything like that. Other mammals, they give birth and nurture their babies. We have people take our babies all the time. Take the baby away, do this, do that, you know, and that's crazy. No one should be doing anything to the newborn. No injections unless it's urgent or emergency. Nothing to the baby. That baby belongs with its mother, and then the mother can decide when and what she would like to be done. Babies do not have to be weighed at birth. Babies lose weight from the minute they're born because they do a big poo, and then they draw on the interstitial fluid that they've been drinking in the uterus to lay down for the first 3 to 4 days till the breast milk comes in. There's no breast milk in the first 3 days. The baby has to build it up, and it's a frustrating 3 days for a lot of people. They think they don't have enough milk, but that's part of the education, talking about how milk production is actually how it actually starts in the female body. Once the colostrum gone, the baby settles for a while, and then when it's ready to feed, it feeds. Boom, 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 boom. It keeps going, and then it has a rest, and then it feeds again. And all of that is very, very normal for survival.
Yeah.
So we don't talk about these things. We just say what you have to do because your baby's losing weight. So they put animal milk into the baby. And animal milk's not really meant for babies at all. It's a standby if you need it, but human babies have the right, from the unique mother to the unique baby, they have the right context in their milk for their baby. And when you look at the elephant to the mouse, they're all species specific, producing milk for their babies. We're in the middle.
I actually, so 2 things. I was watching like the Animal Planet or something like with my daughter the other day, and I can't remember if it was like sea lions. I think it was sea lions. It was saying that they have one of the most nutritious breast milks on the planet because the baby sea lion puts on like so much blubber in like the first, few weeks that their milk is so dense. And then that got me thinking, I'm like, oh, that's crazy. Like that each animal has different composition based on what their baby needs, and how, ours is designed
based on what their baby needs for survival.
Yeah. Right.
Yeah.
But also like things that people don't take into consideration in hospital birth, or if you're on certain medications, is that can impact the baby's weight as well. So I would love for you to talk about that. I've actually never talked about that on here. So if your baby's being weighed at birth, but you've had certain medications in your system, that may give a false weight, as it might have, the baby might have more fluid, retained fluid.
Yeah, you can only, the women who have intravenous therapies, their babies have a higher fluid level, and they have a higher fluid level too. But you can't make a statement about what medications do what till you've read about them and you've read about all the side effects. So I wouldn't do that on this sort of a program, because people have to, or my suggestion, they don't have to do anything. That's wrong. I don't have rules. I have suggestions. And the suggestion is, if you're on a medication, to do thorough research to see what the side effects are, particularly of those particular drugs. And then if I am talking with women and it's feasible to talk with their doctor, we talk about halving the dose and having it twice rather than a full dose. But
Mm-hmm.
that's got to be specific to her what she's taking the drugs for. It's not the same for everybody. And will it work for her is the question too. So she would do a test run if her doctor thought that was reasonable, who's doing the prescribing, or if she thought that was reasonable with the prescribing, knowing herself and her own instinctive knowledge too of self. We
Mm-hmm.
need to take that in consideration. But I that's the way I would go about it. I go about my practice with each individual, unique woman. I don't make statements for everybody because you cannot do that. We are all unique, every one of us. And sadly, I mean, of course, we have to cover a certain amount of information in education, but we don't have enough time mentoring the people coming up into these, professions, enough side-by-side mentoring, knowing that you'll have someone with experience beside you and you're watching and you're learning and you're listening and you're seeing the outcomes. That's really important too. But yes, one of the most common things we see is the sleepy baby syndrome from the epidurals and the opioid drugs that mothers have. So we aim to encourage more women to have sterile water injections if they really need it. But if they have the right person with them during their labour, they generally don't need those things at all. They can work through it. But when they do, and when especially if they have the pre-knowledge, if they've been understanding how it all works before they've had their baby, and it doesn't work the same for everybody again. And I don't talk about pushing because it's a rectal nerve response. It's not pushing. It's the same response when we want to evacuate our bowel. And so it's the worst thing we can do is to tell people to push or not to push, because the mother's the only one that knows the sensation that where her baby is. And if, I don't do vaginal examinations, it's rare for me to do. And the women at home taught me that because I learned from them. I don't need to put my fingers in their vagina all the time for my benefit, because if I'm there with her and genuinely observing and listening, I don't need to do that.
Mm-hmm.
And that's an invasion of her privacy. And again, we don't know her history. And so many women now in Australia, I think it's what at one stage was 1 in 4 young people have been sexually assaulted.
Mm-hmm.
So again, we need to take so much more into consideration before and come back to where women are capable of giving birth to their babies. Women, yes, sure, it's hard work. And it's not going to be easy for a lot of them, and especially first babies, because first babies stretch everything and pave the way for the next baby and the next baby. And then once the ligaments and the all the joints have been moved and stretched, there's a memory, and it's easier generally next time. Sometimes if the uterus is at a point where it's been stretched and there's more room, babies will do flips and all sorts of things. And yeah, we have a beautiful obstetrician and a midwife colleague of mine, another Robyn, in Australia, that are actually working with women who give birth to their what am I trying to say?
Breech.
But yeah, and I was a breech.
Okay.
And I was a breech sucking my toes.
Oh my gosh.
My hamstrings are right up here. So I have still, at nearly 80, I've still got the best hamstrings. I can touch the floor real easy.
Oh, wow. That's amazing. Yeah,
And
I
my mum
mean,
gave birth to me, an 8-pound baby giving birth to me in those years back there. So, time ago.
yeah, I mean, it's really important to teach those skills and to hold on to them, because it's really leaving so many women without any options. And that's the really frustrating part. Because even like in the state that I live in, because earlier you were mentioning like people getting involved in birth that have no reason to be, and that's how it is in so many places. I know like California here, and I live in Illinois, and it's the same. Like home birth midwives are bound by so many things. So are midwives in the hospital, so are midwives at the birthing center. And it's like, just let them do their practice, just let them do their work. But it really, really sucks that like we feel like we don't have any options, like if your baby is breech or anything like that. But I love that you bring up cervical exams, because that's something that I talk about a lot, because with my last baby, I didn't have any. And people would ask me, I'm like 39 weeks pregnant. They're like, so how dilated are you? I'm like, I don't know. And it doesn't matter. Like that number literally means nothing. So there's zero reason to get checked. And that's, I mean, my plan for this pregnancy too. And even in my last birth, I got there in active labor. There was no reason to check me. Obviously, I'm in active labor. Like they didn't need to know where I was. And yeah, that's my plan for this time too. Like you, even as a doula, we learn a lot observing women and giving birth, because that's how we also know how to help them. And you can tell when somebody's in transition. You can tell, there's other ways to tell like how far along they are. And even if there is a stall, it's like this assembly line in the hospital, right? You come in, they check you, they want to make sure you're in labor. Even if you say that you are, they have to verify it somehow. And then they want to keep checking to make sure that you're moving in this curve and in this pattern, but we're all so unique and we don't fit that. Like we're individuals. This isn't like
Absolutely
an assembly
not.
line.
That's right. We do not fit a calculation. We do not fit a calculation. And a lot of obstructed labour, that's called obstructed labour, is due to a baby's fist under the chin. And the
Yeah.
baby's fist under the chin means it can't flex its head. So it doesn't have a leading denominator. It's got a wider diameter coming through. And so we can make allowances for that and we can work with that woman. And I've done that successfully so many times that it's not something that we need to be overly. And if it comes with a lip cervix and you have done a vaginal examination, you know the baby's got its hand under the chin and it's probably got its head on its natural tilt. So when it's born, you'll see, and then you'll see the baby doing this all the time after it's born. It's and you'll say, oh yes. So there are ways to deal with that. It's not obstructed labour. And then they want to start dragging the babies out. Then we get fractured clavicles and we get all sorts of torticollis. We get so many complications because we're overzealous with dragging a baby out. And the other thing we're not aware of, and there's a great doctor here, gynecologist obstetrician here, who's done her PhD and researched continuous fetal monitoring, and phenomenal the outcomes that she's and what she's teaching now, and she's doing literally courses for it now because it's just out of order, totally out of order. And there's no recognition that there's normal fetal heart rate changes,
Right.
and that to do where the baby is and what it's doing to negotiate. It's not so much about there's a major problem, but we can detect when there's a major problem, even if we're listening like we used to do, we can detect.
Right. I mean, that's something that, again, I've talked about. I actually did a webinar a couple months ago, and I talked about this in there. If you want to have like an unmedicated intervention-free labor, how continuous fetal monitoring leads to higher C-section rates, but without better fetal outcomes. So the research shows it. It's not saving babies' lives. It got introduced around the 70s, and you can see here in the States that like around the 80s, our cesarean rate shot up, like right in alignment with that continuous monitoring, because doctors don't all read it the same. That's the thing too. Like each one's going to intervene at a different point. So that kind of shows you too that there's not like this research to base it. And with just the Doppler monitoring, with intermittent monitoring, with just checking in here and there, they're able to detect if there's something wrong with the baby. So the continual monitoring, I can't tell you again how many people are like, the baby's heart rate dropped and I had to get an emergency C-section. And I'm like, oh, okay. Like most likely everything was fine. Like it's the doctors freaking out over the continual monitoring.
Yes, it's certainly interventionist. Interventionisation is just absolutely out of order. And I think it's time for change, and I'll certainly be supporting change around the world, because how come we could do it for all those years and In fact, I took forceps off doctors in the labour ward when I was in charge. I took and removed their trolleys. You can't do that. I said, yes, I can. I had the senior consultant coming and he was always there for me if I needed it. You can't. What are you doing? I'd say to this doctor, washing my hands. I looked at him and he was filthy. And I said, well, yeah, but why are you washing your hands? Oh, I'm going to do a vaginal examination. I said, no, you're not. I said, you're not going near any woman like that. How dare you think you can do that? Oh, I'll put a gown on. I said, no, out, go now. Because you cannot do that to women. And that's probably where I gathered my early strength, having the support of a couple of particular doctors who were very, very decent in their practice, never over the top, and really keen not to have women treated badly. So I could tell you a whole range of stories, but no, many times I asked people to go because it was inappropriate for what they were doing for that particular woman at that time. And that we would call the senior obstetrician and no one else will touch this woman until he's arrived or she's arrived. She was sometimes a bit rough too, so we called him.
Yeah. Well, and that's amazing that you had that support, because that really isn't something that we see here. I actually worked in a hospital here with a midwife group for a couple of years. And they very much were not senior.
No. And they don't realise when all this is happening that they're interfering with the mother who may be choosing to breastfeed her baby.
Right.
And that, they have to also consider not cutting the cord. No one has to cut the cord. No one has to clamp the cord. And it's much better the baby has that blood flow. And they were saying, oh, they had to stop it way back there because of in the 70s, I think it was, because the babies were jaundiced. But the babies are jaundiced every time they get vitamin K and Hep B at birth. Because their little livers trying to break down and bind the drugs, plus any opiates that have gone through. Of course they're jaundiced, unless there's an underlying knowledge of an Rh negative problem. And we might have jaundice of the baby, and there's specific jaundice, but you watch for that carefully, and the history in the pregnancy preferably, and what you need to know for the labour and the birth. So that's the transitions that you're making with that woman. And the more a woman has her chosen midwife for her whole journey, the better she is. And then her midwife has a buddy who, like the obstetricians buddied me then in those days, and then midwives when I was working at home, we buddied each other, and we'd have a buddy in our life. And I've had I've had two major buddies in my life, for the whole of my home birthing as well. And we would come for each other when it was necessary, but our role was to look after our midwife colleague while the midwife continued with the mother. So we didn't actually change over unless someone desperately needed a rest, and then we would do that.
Yeah. I would love to talk about, since you have the Thompson method, what maybe for people listening who they really want to breastfeed, are there certain things in labor and in birth that can impact that? Or what are like your best chances to be able to continue that journey?
Yeah, the impact first starts with a mother lying on her back, being attached to a monitor where she can't move, and her sacrum's flattened the whole time. So she doesn't have enough pelvic space for her baby to descend. That's one of the common. Then there's the, telling her all the negative things rather than the positive things in her labour, and getting her through to her taking her baby at birth. And if she can take her own baby without anybody handling, that's perfect. And then not cutting the cord and letting the blood flow. If she's having a cesarean section, that cord can still have the blood flow until, and they do not need to put a time on it. They're watching the cord, and the cord, it stops pulsating, and that you'll see the blood flow slow down. And then the baby's had the blood it needs, and the placenta's now starting to separate. So, of course, they scoop it out of the uterus, but it's better if it can separate, but that doesn't happen in the operating room as much. But, most important, that baby goes to its mother. It's not got a beanie hat on its head. It's just come from a beautiful water, soft, and this the smell and everything about it is familiar to the baby. The baby needs the mother with a light cover over it, an absorbing cover over the baby to snuggle with its mother, so that now it's with its mother in the outside world, and it's secure and nurtured and safe. And you can still observe a baby when it's with its mother. You don't take it away to do the APGAR score. You can actually watch. So,
Right.
yeah, so I think there's a lot of relearning or returning to women and relearning a lot of the skills that, thank goodness, came through an era where I was fortunate to have that skills and to have the mentoring that I did. You know, that was really important to me, to have that mentoring. And, you know, it did start to change in the late 60s, 70s, slowly. It depended on who the midwives were, how tough they were, what they wanted to. Uh, but, you know, once we put women in a labour ward, that's different to her giving birth, right? So we want her to give birth in the way that she chooses to give birth. If she's choosing to go into hospital, she as mobile as possible, and to do the body movements and the places and to be able to have access to deep, warm water to be buoyant in if she needs it. Some of the most beautiful births are in the water. And because people say, oh, you have to have this temperature, not everybody is sensitive to the same temperature. And, you know, of course, we don't overheat the water so the mother can't, you know. But the buoyancy in the water and just what's right for her is so important. And understanding that you can observe carefully lots of things to know how a mother's progressing without all the medicalised things that we learn. And yes, we need to have our relationships with our special medical colleagues. So if there is a need to transfer and ask for help, and ask for help, we're coming in from home, which I never, ever, ever had a problem with, ever. I was always welcomed. And so I think that doesn't happen anymore.
Mm-mm.
Some midwives aren't even allowed to go in the ambulance with the woman, and
Right.
she's not even, and, you know, it's crazy. So I think the ownership of the woman has to be gone. There's no
Yeah.
ownership of any woman at all. There's no dictatorship of any woman at all. None. The only time in our law legislated is when the senior medical officer is called and has to make decisions in an emergency situation. That's the only time. And that doctor will make decisions for the woman. And we will all agree with that because that's the emergency situation. Hopefully we can prevent the emergency situation, but not always. So we don't know. And none of us know now what's going to happen hours later. We don't
Right.
know. We can only watch the progress of labour. And we can go by everything that we're seeing and working with that woman. We cannot. And then we come with the breastfeeding and we protect her. And we protect her to have her baby. And if we watch carefully, that little baby is so, if it's not affected by opioids, is so alert to survival, it's already starting within the hour to find its way to the breast. And I have some beautiful video clips of that over time, knowing what to do, knowing how to do it. And then with my skills now, I can fine tune some of the things that have caused the problems with the nipple trauma. And so by passing that on before I die, I hope many, many more people will be able to do that too.
Yeah, that's wonderful. I know that where I live, if home births transfer to the hospital, there definitely are issues sometimes with just even the hospital staff not respecting that woman very well because she started at home and they think that she's stupid for doing that and just things like that. And I'm like, man, I would kick somebody in the face. Like, I don't even think I would care. Like, I would be so riled
Yeah.
up because again, I get so passionate about this and I get so frustrated with some of the stories I hear. And my goal for this next baby is I want to try to catch the baby myself. My husband caught the last one. And this time I want to try to catch the baby myself. I've never I don't even remember what the last one if I felt down there. Every time that they're like, "Do you want to feel the baby's head?" I'm like, "Nope, nope, I'm good. I'm in my zone. I don't want to touch anything." But I think this time I'm a little bit more curious, and I want
So,
to.
so you're giving birth to your baby and you're taking your baby to you from
Right.
the inside to the outside.
Mm-hmm.
So, and most of us will have a fetus ejection reflex if we let it
Yes.
happen. And so then we take our baby. I just think this beautiful sensation of babies on their mother's chest, close to the breast, is the perfect way to be. However she chooses to be, whether she's sitting, whether she's standing, wherever she is at any one point in time. Even the women who give birth out on the road, they still need their baby, and more so there because they're in a foreign environment. So, and that happens a lot here because they've closed down all our community birthing places, and they
Oh,
thought
wow.
it was safe. Politicians did that back in the 80s, 90s, 80s, 90s, I forget now, 2009, I think it was, they started, and they closed down all the small hospitals, all the small community birthing homes, and then gradually the birth centres were all closed down too. So that meant that all women were transferred to public hospitals, and then the private system started to open up as well. And so there's public and private here. So that's what, depending on what the woman wants, and as far as paying health insurance and that sort of thing. But it has changed things. They were doing this to save money. Guess what? It's cost much more money by doing this in the public hospital system where sick people are supposed to have beds.
Yeah.
Genuinely sick people. And we take up whole areas of public and private hospitals where the sick people could go.
Mm-hmm. Yeah, that's
You know,
wild. Yeah, I feel like the government, like you said before, I mean, they just get involved in things that they shouldn't be involved in. And when it comes to things like this, it often backfires because it's like, yeah, that doesn't make sense anyways. Like, why, we see that even here with like the modernization, obstetrics taking over midwifery care, them making midwifery care illegal in several states, making home birth illegal in several states. And there's still some where home birth midwives are illegal in the United States, which
the
is,
women need to
yeah,
stand up
it's
and be.
mind blowing. It blows my mind. Um,
So if that's the case, women can have their babies and not call anybody, and that's called free birthing here.
yeah.
And
Hmm.
that's actually happening as well
Yeah.
because they don't have a choice because everybody else is taking over what they would choose to do. And
Right.
those women choose to go to a hospital, yes, but we wouldn't need as many occupied beds. That's why they transition them through the system so rapidly. Oh, sorry, no, you can't stay here. There's another woman in labour. That's my birth space. I'm staying here. I'm not going anywhere. This is
Hmm.
my birth space. This is where I've been directed to come.
Yeah.
So,
That's
uh,
wild. So I would love for you just to tell us a little bit more about the Thompson Method breastfeeding program, because people can take your course, and also be certified so that they can help other mothers.
mm.
So can you just tell us a little bit about that?
Yeah, I can tell you a little bit about that. We have, thanks to my colleague Rachel Austin, we've known each other for many years, and she's taken over the head of education. And together we work out that we've worked out with my team. I have a magic team who look after us, all of us, and I don't even do my own diary. I'm so lucky. But it is about sharing information. And there's two levels. There's the educators level, which has a scope of practice, and there's the practitioners level, which has a different scope of practice, like the midwife would do. And you must be, for the practitioners, you must be registered with a registering authority to be able to become a practitioner, a regulating authority that fits within the area of work that we're doing. Can't be a regulating authority for something that doesn't fit with what we're doing. And then they go through the course. They do the course. They do all the they do the live sessions with us. We assess them with women who offer their services to come and do a feed on, mostly online. We assess that online. They watch all the videos that are applied in the of what we're doing in the program, and it's all like, I just go with the flow because I'm not one of those people that is obstructive in the way that I might be obstructive in the way I'm talking now about what's happening to women, and I'm not being obstructive, I'm leading. I'm not actually being obstructive, I'm leading what's right for women because people don't understand, and having had the experience. But I want more and more women to decide what they want to do and who they want to have with them. And then if there's people in their community that can help them with the breastfeeding, they can help, the educators can help prepare them in pregnancy, and then the practitioners can help them, when they need it for anything that's need to be helped in a deeper level with the breastfeeding. And, most of them are doing really very well. It is a learning process, because I can't tell you, I never ever dreamt I would have done what I've done and now know what I know, of all the underlying things that happen as well. We don't go any deeper than the breasts, and often they're regarded as sexual objects, so they're not looked at in the way that they're needed for the baby as well. And in past history, families and parents have had a difficult time. So I just heard this morning when I was out for brekkie that, her mum shoved her baby on the breast, and she said, and she was in so much pain, she was crying, and her mother told her to get on with it, but this is what happens. Do not shove anybody, nobody, not the tiniest little baby, to the oldest person on the planet. You do not shove them by the back of the head, ever.
Yeah. I mean, I
So,
feel like that's kind of how the lactation consultants in the hospital when I had my first baby were a little bit.
and in fairness to them, they were educated that way over the last 50 years that I know of. Yeah. And
Yeah.
then probably longer. Yeah.
Right. You just kind of like hold your boob with this hand and shove their face in with this hand.
Yeah. Well, that's the absolute, no doubt, reason why we have so many women with complications. Nipple trauma in my research was the highest, and I couldn't believe, and I just am so ever grateful for the women who let me take photographs of their nipples because I was so horrified to show
Wow.
in my research, and it's in my thesis, just how terrible those women were suffering and how their breasts were, because everybody said the baby had to have animal milk, and animal milk means their breasts, they're not working the breasts for their milk to come in themselves. And so now they've got the most horrific engorgement, horrific preventable engorgement, and then mastitis. They were the three most common things that came up in my database. And and so thanks to my guru professors, that they directed me in, research and analysing, and we had some of the best analysts look at my work so they could, make sure that it was all a bit overwhelming for me, because I wasn't into that. I'm into working with that beautiful woman and her baby, and I'm not working with her, I'm just there beside her, really. That's another thing. I've got a whole module on language, and I have to try still to change my own language, because it's really important how we talk with women, and that we don't talk to them, we talk with them, and we learn much more that way. So breastfeeding became, for me, this part of my career, an unknown entity. I did not know I was going to be doing this. And, I've done so many, I've been called to be a consultant to build a whole new midwifery unit with the architect. I've been set up birth centres and done all sorts of things by invitation, but I never ever dreamt I'd be doing what I'm doing now.
That's amazing. And I mean, that's obviously just also a testament to your passion for genuinely wanting to help women and helping them be seen and heard and validated in their experience, and for you to not only do that, but for you to be a continual learner, like that you're learning from each birth that you're at, that you're learning from each breastfeeding experience that you're a part of. Because I feel like, yeah, we're in this model where doctors are just here to teach us like we know nothing,
And
versus
you know,
like,
they talk about, there's people talking about all breasts do the same thing. If they saw as many breasts that I see every day, almost, a couple of days off if I'm lucky, and then for years and years, they would understand that there are no two people with breasts that are the same, with nipples that are the same.
mhm,
And so working with that unique woman and her unique baby is the most, not working with, observing that unique woman is the most important thing to learn. It's
yeah,
not about learning about what everybody should do and how they should do it with their breasts and their nipples. It's being aware of where her trauma is, where her pain is, what she's feeling, asking consent to do a feed with her, to look at her breasts, to look at her nipples, look at the direction of her nipples, and it's, you know. And I've had two women that have breastfed babies with one breast. One was born without any glandular tissue in one breast. She fed four babies till they were two.
wow,
She's written a book, and she started food a little bit earlier, and she has four brilliant kids. And then there's another one who was born with an abnormality of one breast, no central nipple, one way down the bottom and one way up the top that was really not a nipple as such. And so she couldn't use that breast. And so she fed from one breast too, no
mhm,
problems.
yeah,
And again, we turn the baby over, so baby's using left and right brain, but we don't in those circumstances. But there's hundreds and hundreds of stories one day I have to write, but timing is the problem.
yeah, yeah. Well, maybe you can just like dictate them, like into
Yeah.
a recorder or something, and then somebody else can write them for you.
Oh yeah, but I have to make sure that it's right, you know.
Right, right, right.
Sometimes
Obviously,
when
you'd print.
others edit it, they edit it in a way that's not the appropriate way
Right.
for passing on information and being able to understand it as individuals ourselves. I have
Yeah.
been very fortunate with the support and the help, and even with the expert man who was world expert with nuchal ligament, the nuchal ligament, whiplash injury man he was. And I rang him for his advice because of what way I was seeing the babies react.
Hmm.
And he said, "Oh my goodness, Robyn," he said, "I've never even thought of it." He said, "I've never seen it." He said, "So I can't really say anything," but he said, "You're onto it." He said, "Keep going." So, you know,
Yeah.
that like, wow. And he's an expert.
Right, right. Well, and there's so many things to take into consideration, like you said, and I feel like with breastfeeding too, that's another thing where, again, there's lack of support and education. It's something like 80% of moms stop breastfeeding before they want to. And then there can be so much also guilt and other things that come with that. And so if we just have the support, the resources, the education that we need, it would just be so much better. I know with my first, breastfeeding didn't get easier until she was about 6 months old. It was really,
Mm,
really tough for me.
mm,
And then with my second, it came pretty easy. So
mm.
I'm hoping
And
this baby does.
I must give credit to my professors. I did not call it the Thompson method. My
They named
professor,
it after you.
they said, this is you have done so much work here. And then after I'd been awarded my PhD, they did a review of all of the literature, and apparently, allegedly, according to them, I'm the only one in the world that's looked at breastfeeding this way.
Hmm.
So as deeply as I did at that stage, I spent well, I'd been years working with them, but 6 years, say 5.5 to 6 years, you know, thinking something's drastically wrong here, and that was how it all unfolded. Mm.
Yeah, I'm gonna
So
have to look into your course, and I'm
the
gonna put
Thompson,
a. Oh, go ahead.
that's how I came across. That's how I came to be named the Thompson method.
Nice. I'm going to put a link to your course in the show notes for anybody listening if they want to check it out, if they want to take it. I'm definitely going to look into it. I feel like I've been breastfeeding since my oldest was born. So I tandem nursed for 6 months with my last two, and then I'm still
Brilliant.
I'm I'm gonna give birth here in a couple months, and I'm still breastfeeding my 19-month-old. So I'll probably tandem with them for a little bit. So I just feel like I've loved it, but it's also right now I'm at a point in my pregnancy where my nipples are really tender. And so
Yeah.
breastfeeding's really tough. Like I wince every single time she latches because I don't want my nipples touched at all. Like even them rubbing on my shirt like hurts right now.
That could be a message that the colostrum's there ready for the new baby.
Yeah, well, that's what I thought this last week because it got way more tender this last week, and my 19-month-old just started wanting to breastfeed a lot more, and I could hear her
Yep.
gulping more.
That's it. That's it.
Like,
She's wanting to, yeah, she realizes it's changing and it's changing for the new baby. But
right,
then when your milk volume peaks, then she'll be very valuable then because she'll help you
right,
regulate your volume. Yeah.
right, which is why I really want to continue through because I realized that with my last one, because with my first, I did end up with some engorgement issues and some other stuff because she was in the NICU. And so I was pumping a lot and nursing. And then when we got home, I didn't really want to pump. And
Can
so
I add, can I add something else there?
yeah,
I don't talk about pumping because that's what they do to the cows. All the mechanical things we have are set to do what they do with the cows. We express our breasts in a rhythm and a cycle, and it's gentle. It's not. Uh, uh.
yeah. That's how I felt every time I did. I was like, I feel like a cow. I feel like a dairy cow. Um, I ended up after my second just really not needing to do that at all because I was working from home more, and I found that the manual pump was just like way better than any automated thing for me, way gentler, way less painful. Um, but I realized after I had my second, I had a little bit of engorgement again, and it helped having my toddler nursing too. Um,
Yeah.
so it did really help, I felt like, regulate some. And then yeah, after about 6 months, I was like, all right, I'm done. I can't do both anymore.
That's
So
right. And this is what happens because that's instinctive knowledge.
mhm,
Right? You're using your instincts. So you have a little conversation and you work it out between you, whatever's right for you and in the moment all the time. Because if you use your instinctive knowledge, you'll never ever be wrong. And what we don't listen to is women's instinctive knowledge.
right.
Yeah.
Yeah,
Knowledge of self, their knowledge of self is phenomenal.
right.
Mm.
And I also feel like, I mean, we've been taught though not to trust our instincts, like I was saying earlier, or to be like, is that really what my gut's telling me? Or is that fear? Or is that this? And just really questioning ourselves, which I think starts at a pretty young age. So I do think that
That's
that's something
your,
that's so important.
that's your positive voice, your negative voice talking with each other until it knows, it comes to you. And that's the debate that goes on in our heads. Yes, no, I better not. And then, boom, I'm doing it because, yes, I know.
Right.
Instinctive knowledge, we need to encourage it. It is the best for everybody, actually, instinctive, but particularly when you're a mother who's just given birth, who's got a little baby in her arms, and knowing about her baby in a way that nobody else knows. No one has sensed that internal growth. No one is incensed that sensed the descent of the baby, the birth of the baby, like the woman has herself.
Yeah.
And we have knowledge that internal knowledge. We have knowledge that people don't understand. They don't know. They might have given birth themselves, but it's still not your birth or my
Right.
birth. Or yeah, it's all about our own instinctive knowledge.
Right. Right. I love that. I love that.
Yeah.
Yeah. And I think again, yeah, it's just something that we really, really need to come back to tapping into as mothers and not medicalizing everything, not feeling like we have to I don't know, the research every single thing. So that was a problem for me with my first. It was like almost like Googling too much stuff instead of like tapping into
Social
what
media
she
is a
needed.
problem. Social
Oh,
media is,
totally.
yeah, because people think they can do what that person done, but they just tune into themselves, they'll know
Hmm.
exactly what they need to do. And it's fear generated often by people around them. There's all these things, and there's fear generated heaps through social media. Yeah.
Yeah, absolutely. Well, I just want to thank you so much for coming on. Before we wrap up, I always like to ask the guests, since the podcast is called Morning Hava, how do you take your morning coffee if you drink coffee?
How do I take it?
Hmm.
Well, at the moment, for the last, say, 6, 8 months, I've been having um, turmeric latte.
Oh,
Yes, and I have a small coffee in the morning with turmeric and with almond milk.
okay. Is it like a turmeric powder that you put in there yourself?
No, it's a liquid.
Oh,
Yeah,
okay. Interesting.
liquid, and it's really nice. And then there's on top they put a spice. What is it? They sprinkle the spice on. God, that's a common one.
Like cinnamon or
Yeah, cinnamon, that's it.
cinnamon.
And
Yeah.
they put that on top, and it's a really nice little glass. It's hot, and I just sip it. It's beautiful. Love it.
Yeah, that does sound really good. Sounds like something that would be up my alley for
So tell
sure.
me, why do you ask about coffee?
Well, just because, so since the podcast is called Morning Hava, I like to just ask a fun question at the end, like how do you take your morning
Oh,
Java,
okay.
since Java means coffee. So it's just kind of like a fun thing. 'Cause a lot of times on the podcast, we dive into obviously like birth things or serious topics. So then it's just like fun to ask like a fun question at the end, you know?
Okay. Yeah. See what I mean by why? Ask why. Ask why.
Yes. Yes. Well, so that was something too with my husband that I didn't realize, because he would come with me to some like my prenatal appointments.
Yeah.
And that's one of the reasons why I loved the midwifery care that we got, because our appointments would be like 45 minutes long. And they just really, like, I just had an appointment yesterday and she's like, so how are you feeling? What's going on? Are you doing anything to prepare for your labor? Like, it was just, they're so intimate, and like, it's just so different than in and out, you know?
Yeah.
Um, and so he would come to the appointments and ask so many questions.
Good.
And
Good.
yeah, and that's just how he's always been. Like, even
I
if he has
love
to go
it.
to the doctor for anything, he's like, okay, why are you doing that? What are these tests for? What's going
Yeah.
on? What if this thing happened? Like, that's just how he is. And so I remember asking him once about it, because I don't know where I got my like medical insecurity of like, I feel like I'm going to annoy them if I ask too many questions, or I'm taking up their time and I shouldn't be, or, um, they just like kind of dismissing myself. And he was like, no, he's like, you're supposed to. Like, I was taught that even as a kid, just always ask questions. As a kid, if they're drawing my blood, okay, like what are you drawing my blood for? What are these tests going to be? What are you checking now? What are you doing? And that's just how he is. So I feel like he taught me to be able to be that way a little bit more. But I feel like we get at a young age kind of like this medical complex of like, I'm almost scared to ask my doctor too many questions, but it's like, that's what they're there for. You should ask them all of the questions.
Yeah. I think because society over the years has put them on a pedestal,
Totally.
instead of them being part of a whole generation of teams of people, they put them on a pedestal. And
Yeah,
sure, some of them
that's
have
where
skills
baby
that
rock
others
fits.
don't have. Sorry.
Sorry. Can you just start that pedestal thing over? My
Yeah, I
computer
think
cord went funky.
uh, I think that it's over time, over history, people have put them on a pedestal,
Yeah.
right? Now things have changed where their mentoring is not the same as it was. And again, lots of them are in big trouble with women. In my experience, with what women are telling me and what's happening around the world, they're in big trouble with women and midwives and other professionals asking questions about what they're doing, why they're doing it, and what possible causes of, are they talking about the benefits, the risks, the alternatives, your right to say no, your right to seek
Right.
another opinion. They're not asking you, I'll go and seek, would you like to seek another opinion?
Right.
Some might, but few. And so the law of consent's sort of flown out the window for a lot of professionals. A lot of professionals don't ask consent. And it really is important for people to know know their laws in their country about consent.
Right. Yeah, definitely agree.
Yeah.
Well, I just want to thank you again so much for coming on. Like I said, I'm going to have a link in the show notes where people can take your course at. If you end up coming out with a book or anything like that, let me know. And I'm really excited for everybody to hear this podcast. I mean, you have so much wisdom just being a midwife of 50 years. I feel like I could talk to you about so many different things. But I just want to thank you so much for your time and energy here today.
Thank you, Elizabeth. Beautiful. Take care and happy birthing.
Thank you. I'm so excited.